thank Prof. Now we will move to the next speaker, Dr. Zuhair alhassnan. Prof. Dr. Zuhair alhassnan is one of King Faisal Specialist Hospital consultant, and he is the one figure of genetic and newborn screening. Dr. Zuhair alhassnan will talk about cardiac genetic disorder. Thank you.
Assalamu alaikum. Good morning. It's really a pleasure to be with you in this beautiful region. I visited Jizan when I had the pleasure of working in newborn screening. That was, I think, 2015. And I'm seeing it this morning coming from the airport. It has changed a lot. And mashallah, I was very impressed by the advances that you guys are seeing in Jizan. And I hope the best, inshallah, in the future. Thank you, Dr. Awaji, for the invitation. It's really a pleasure to be with you this morning. And I would like to show you some of the work that we've been doing over the years with respect to cardiogenetics in King Faisal, and especially the cardiovascular program. And I will focus on the cardiomyopathy. So if we look at the cardiology causes of health burdens globally, it consists of about 30%. Almost 1/3 of the death globally is caused by cardiac disorders, and there hasn't been a significant change over the past decades in terms of the mortality and morbidity associated with this major health issue. And if we look at, from genetic standpoint, how we classify these cardiac disorders into monogenic, oligogenic, and polygenic, and try to dissect them, the monogenic diseases have the traits of precise diagnosis, cascade genetic testing, targeted therapies, risk stratification, and obviously the productive options by PGD, carrier screening, and prenatal. Whereas in polygenic disorders, it's frozen. Where in polygenic inheritance, it helps you in terms of the diagnosis, risk classification, phenotype diversity, disease modifiers, and prognosis. Now, this is the data that we have over almost 15 years. When we started the program in 2008, we have so far almost 4,000 cases and relatives with more than 1,200 families, and we've learned a lot from the collection of these cases over the years. And I'll show you some of the data. Generally speaking, cardiomyopathy, if we look at the dilated cardiomyopathy, it has an incidence of 1 in 2,700, whereas abortive cardiomyopathy is much more common, 1 in 500. And it is the leading cause of death. And you may have heard over the past couple of months stories about athletes who have all of a sudden collapsed in the field and they were found to have cardiac disorders. If we diagnose a case with dilated cardiomyopathy, it is mandatory to screen first-degree relatives because there is a chance of having about half of the cases in the first-degree relatives to be affected with cardiomyopathy. So this is very important. Second step, once the diagnosis is made on the index case. If we look at the genetics of cardiomyopathy, which is typically associated with adult onset disease, there are major players in hypertrophic cardiomyopathy. These two genes, MYBPC3 and MY7, represent about 80-90% of the cases. So if you select these two genes, you'll be able to detect most of the adult variants of hypertrophic cardiomyopathy. But the situation is much more complex in dilated cardiomyopathy. This is just a very partial list of genes involved. there are no major players, except one, the TTN, which is the largest protein that we have in our body, a titan. About 20% of the cases are having mutations in TTN, but there are no major players. And therefore, if I have a DCN or that cardiomyopathy, I have to do next generation sequencing with a panel or exome or genome sequencing. So let's see how consanguinity in our population has impacted on the clinical presentation and phenotype and the unusual presentation of cardiomyopathy. Now, this is a very similar work that was done in Finland, addressing severe infantile cardiomyopathy that may require transplantation. So then the yield was about 40%, and they adopted different techniques of genetic screening. As you can see, many genes involved, there are no major players. So we wanted to see the differences between what is observed in the West compared to what we see in Saudi Arabia. So we've collected about 205 cases. And the consanguinity in these families were 90%. Mostly GCM and HCM cases, very few cases of restrictive cardiomyopathy or non-compaction. Now, the approach that we've adopted is that if there are clinical clues or suspected founder mutation, we go immediately to the target gene, either full gene sequencing or target mutation, if we know that this is the prevalent mutation in the tribe. If there isn't, then we go immediately to the whole genome or whole exome sequencing. We did not apply the panels. So this is the Finland study. Almost half of the cases were de novo, out of 66 patients. Now, this is our study. Out of 205, the detection rate was about 50%, and almost 90% of the cases were autosomal recessive. That's a clear reflection of the high incidence of consanguineous marriages. And also, when we analyzed the data, these 4 genes, FLNC, MYLK3, NEXAN, and BCL, had been reported several years ago with dominant cardiomyopathy. Now we are observing recessive forms of cardiomyopathy, in which there are hypomorphic alleles in the parents, they're fine, but their children having severe phenotype and they are affected. And also we have the opportunity to uncover novel genes. And at least 2 genes are now confirmed to be associated with cardiomyopathy out of these 7. One of them is the FL2, which in collaboration with a group in the Netherlands, they were capable of generating a model with a knockout model, collected with 3 families, 2 were from our cohort, and that had shown in the animal model that there is abnormality at the trabeculation of the myocardium, which leads to the cardiomyopathy picture. Doing this longitudinal study of analysis for many years gives the opportunity to understand the phenotype in deep. And this is one of the genes, LTB3, that had been associated dominant for. Now, again, in collaboration with groups in Europe, we have now confirmed that LTB3 is associated with a fatal recessive form of cardiomyopathy. And I would like to emphasize the importance of having a focus on genetic diseases in addition to a combination of data over the years. And this is a very classic example of how we learn from doing this longitudinal study. This is a family that we've been following for many years. And then this case had a mutation in this very rare gene that is causative of cardiomyopathy. And over the years, we've learned that this loss of function variant associated with this gene is associated with variable phenotypes. So you may have a child with cardiomyopathy, you may have another child with cardiomyopathy and glaucoma, you have another child with cardiomyopathy, cleft lip and palate. And if you have only one spot of analysis of this family, you miss this opportunity of having the variability of the presentation of the genotype. So this is the importance of having a longitudinal analysis of the data. What about the outcome? Let's focus on this particular aspect, on Pompe disease. And if you look at the gene mutation that are exception of one mutation, the nonsense mutation, which is prevalent in the northern part of the country. What we have adopted recently is immunomodulation, depending on the CRM status, a CRM negative or CRM positive. So this is the old cohort of 20 cases that had not received the immunomodulation. And the yellow bars indicate the age of the start of the enzyme replacement therapy. So we had patients that were started at the age of 2 weeks, and we have patients that were started at the age of 1 year. And look at their outcome. 18 patients died out of 20. Very significant mortality rate. And this is irrespective of the age of the start of the treatment, whether you start early on or you start late. And this is irrespective of the mutation, whether you have a mutation that is a CRM positive or CRM negative, nonsense or nonsense. So it's a severe phenotype that we have in this country. Now, this is the outcome of the immune modulation. 8 cases, again, the yellow bars indicate the age at the start of the treatment. We have infant who was started at the age of 10 days, and we have one who was started at the age of 3.5 months. So the CRM, 2 were positive and 6 were negative, who was capable of walking, 6 out of 8, whereas in that cohort, only 3 were capable of walking independently. And who was still alive, 5 out of 8. We've lost 2 patients. They live in a remote area, and they had chest infection during COVID lockdown. So we were not able to bring them to Riyadh. And unfortunately, they died in the local hospital during that acute event. If you compare the survival between with or without immunomodulation, and after 1 year of treatment, so it was 20% compared to almost 90%. Significant difference between the two. Walking independently, only 50% without immunomodulation, 75% with immunomodulation. Significant difference. Yet, I think we're still learning about the use of immunomodulation in myosine. And I think when we start a treatment for this particular condition, genotyping is very important, so you can have a precise approach. In addition, counseling the family before we start the treatment that this is not a cure. It is a palliative treatment. It's improving the quality of life. So they will have problems, and definitely the morbidity associated with this condition has improved significantly, but it is still a lifelong commitment. With respect to the prognosis, this is a very important study from literature that shows that if you have a truncating variant, then you have a prognosis that is poor. So this particular gene, FLNC, presents about 2% of cardiomyopathy. But if you have this, then there is a higher risk of arrhythmogenic cardiomyopathy and fatality compared to mutations that are missense, for example. Here in our population, we've come across this particular family in which they had a history of death of 4 infants during the age of 3-4 months with severe hypertrophic cardiomyopathy. And we had a DNA sample from one of the affected, and the exome sequence identified a mutation in ELAC2. And ELAC2 is now considered the most common cause of cardiomyopathy in infants in this country. It is amazingly very common, especially in one tribe in the northern part of the country. And universally, almost universally, fatal within the first year of life. Very interesting example in literature with respect to the genotype and environment is this particular gene. If you have this dysmosomal mutation, one of the dysmosomal genes, if you exercise, then your survival is less. Because it induces VTAC, ventricular tachycardia fibrillation. So once we do genetic analysis and identify a patient who has this particular gene defect, we advise against exercise. And those who were advised against exercise, they have decreased risk of VTAC and ventricular tachycardia. So this is a genotype environment interaction. You have a genotype that can induce death because of exercise. And the survival curve, if you look at the big panel on the right side, is really interesting. So if you do not exercise, you're fine. If you exercise, your risk of death is very high. 2 words about recent advances in cardiogenetics, the PRS, or polygenic risk score. And this is a very similar work that was published in Nature Genetics, and it started all of this very high profile talk about PRS. So that was a genome-wide polygenic score of 5 common diseases, including coronary disease. And heart diseases were the top. So 8% of the population had greater than 3 times increased risk of coronary disease, which translates into a risk that is very similar to recessive diseases. And their conclusion, their statement at the end of the article, it is time to contemplate the inclusion of PRS in clinical care. And that was in 2018, and everybody was excited that PRS will be in the clinic very soon. But look at the recommendation of the American Heart Association very recently about PRS. Now, among middle-aged adults, coronary disease, PRS, performs similarly to conventional risk factors and provides additional prognostic confirmation for coronary disease. However, the clinical significance of this improvement is contentious. We're still not there yet. We're learning, but we're still not there yet. So it is not until today recommended to be included in the clinical care. And what is also going to shape the way of approaching cardiogenetics is this. It is not only the mutations that we calculate and score the PRS. It's much more complex than this. And we know that cardiac diseases are very, very complex. So it is not the variants that we identify. It is association studies, it is the multi-omic, including the protein, the transcriptomes. It is phenotyping, including lifestyle, diet, smoking, exercise, the PRS, and also including the AI that can have all of this information, analyze it, and then give us whether this patient is at risk of developing disease A or disease B. So the GNR is going to also be implicated in the clinical care, but I think we need more time before we get to this stage. Very important development is this, which is the use of gene editing in trying to cure patients with cardiomyopathy. And this is a work that utilized CRISPR-Cas9 editing system in order to correct the mutation in the famous gene associated with hypertrophic cardiomyopathy. And it was shown in this paper that it was very efficient, accurate, and safe. And therefore it can be utilized in PGD. Therefore you can correct the mutation, and then in that particular situation, you'll be able to prevent the disease from happening in the next generation. And I think we will see more and more examples of this in the near future. But let's go to the basics. Now this is a family that we came across with 2 affected children with congenital heart disease. So we did genome analysis, and the lab reported a homozygous in this particular gene, which is associated with Lewis disease. It has nothing to do with congenital heart disease. But the lab reported pathogenic variant in BRCA1. And there was an extensive discussion about the implications of this finding. The lab forgot that our clinical question was cardiac. It was not oncology. And they listed the risk of different types of cancer. It just diverted us from, and the patient from, the main clinical question. So the secondary finding is a very important aspect that we have to deal with, we have to live with. So this is one of the largest studies that analyzed the chance of having secondary findings if you adopt exome or genome analysis. So it's about 3%, and mostly cancer susceptibility genes. And therefore it is very important when we adopt this that we do pre and post genetic counseling when there is a chance of having some families come to us with exam results, and they're not aware that they were screened for the secondary findings. And this is, I think, ethically not acceptable. It is important to ask if the variant is pathogenic. Is the variant causative? But more importantly, is the gene relevant? Sometimes the lab reports a gene variant, but it has nothing to do with the question that you have in the clinic. And I'll give you a very good example in cardiogenetics. You may be aware of this effort that has been led by NIH to curate the associations of genes and phenotype. And this is the recent data that just pulled yesterday. So they have curated almost 2,500 associations between genes and phenotype. And look at the number of associations that have been either refuted, disputed, or limited. More than 550 associations. A striking example is in cardiogenetics. Long QT is a very striking example. Another one is direct cardiomyopathy. So this is analysis of genes involved and reported, even in almond, that has been associated with cardiomyopathy. But look at the analysis. Very careful analysis of genes, disease association. Out of 51 genes, only 19 high evidence. Only 19. And when they analyzed 16 commercially available panels for cardiomyopathy, many of these genes on the right side, which have very low evidence in associated cardiomyopathy, are still reported. So you may see a lab report that shows an association of a variant with one of these genes on the right side. And even you can check almond, and it is still listed in almond that is associated with cardiomyopathy, when in fact there is no strong evidence. And this is very important on our side as a clinician to be very careful when we analyze the lab reports. The lab does its duty, but it is our duty to dissect, analyze, and try to understand the implications of this finding. Last, the suggested approach. And I think it's very important when we have a cardiac case, a cardiogenetic case, to do this. I know it is very ideal, but at least let's try to reach to it. So if we have a confirmed case of a cardiac disease, suspected cardiac disease, refer to cardiogenetics, implement management guidelines by our colleagues in cardiology. Pre-genetic testing counseling, obtain family pedigree and informed consent. Request relevant genetic test, and that depends on what you think is the most appropriate, and obtain blood samples. And then let's see the results. It's either positive or inclusive or negative. There are no three categories here. It's either positive, inclusive, or negative. Let's go to the positive. Now, if it is positive, we may modify the management. And for example, cases in which there is a truncating variant, there is a high risk of sudden death, and our colleagues in cardiology may implant ICDs. If there is a mild mutation, they may just observe. So the interaction between our colleagues in cardiology is very important. Post-genetic testing counseling and also do preventive intervention that we all do in our general genetics. And then screen the family members. Once we found a positive pathogenic mutation, first-degree relatives should be screened. If negative, reassure, no need for surveillance. If positive, then refer to cardiology for management. Now, the main problem is in the inconclusive and negative ones. Now, review with cardiology. Are we dealing with cardiogenetics? Are you sure that there is no explanation from your side that this cardiomyopathy is not related, for example, to hypertension or long-standing aortic stenosis? Review with cardiology, post-genetic testing counseling, and then cardiac screening for at-risk family members. So the lifelong surveillance in that particular aspect is missing in this country, in which once we find someone who has cardiomyopathy and we try to screen the first-degree relatives, the surveillance, the lifelong surveillance, is missing. It's very hard to have eligibility for these cases, to do it lifelong, to do echo, ECG, cardiac appointments. It's very tough. Now, if it is positive, if you happen member with cardiomyopathy by echo, then you're dealing with a genetic disease. It's true that your genetic analysis is a negative, but it's very likely that you're dealing with a genetic disease. Then review the case, maybe you can do research, extend the analysis to genome, etc. If it is negative, even if it is negative, you need to do lifelong surveillance because you may be missing the mutation. And therefore, this is really a major issue. And this also applies to some extent to cancer. Imagine this is a breast cancer, not a cardiac. It's almost similar. We have a problem with the lifelong surveillance in this country for the family members who are having positive mutation or a family member who is positive for a cancer that or mutation. Okay. Lastly, I would like to thank the members of the program, our postdoc fellow research assistants, coordinators, and genetic counselor, my colleagues in the center, as well as collaborators. I had the pleasure and honor to be working with His Excellency Majid Al-Fayyad, who was the co-founder